Hi, my name is Rebecca Roden. I'm an assistant professor and a clinician scientist in the Department of Geriatrics and Palliative Medicine, for those who don't know me. And I'll be speaking today to give you an overview of medical assistance in dying. I have no disclosures or financial conflicts of interest to report. And in this talk, I'll be reviewing the terminology and legislation around assisted dying, and we'll examine some of the clinical and demographic data in places where it's been legalized. And we'll really focus in on trying to understand the practices and safeguards that have been put in place for assisted dying in the US, Canada, and abroad where it's been legalized. And we'll end by considering the role of palliative care specialists and geriatricians in this domain. So this talk is not meant to be an endorsement of any one side or particular opinion or practice of one side over another. And it's really not meant to antagonize anyone with differing views. This talk is really meant to be a review of things as they are, current practices, laws, and data, and how they might be in the near future based on existing data and my experience. I'm trained in medicine in Canada, where medical assistance in dying was legalized. So I'll be bringing a little bit of that to bear, as well as what's happening in the US and abroad. So a bit about terminology. There are many terms and labels that get used in this discussion. Each of them are laden with some moral position in some way, but we'll go over them so we can have a common understanding of what we mean. The first terms that were often used in assisted dying was actually assisted suicide, and that was the initial beginnings of the discussion around assisted dying that took place in the earlier 20th century, or even honestly in some places up until the early 2000s, but it became synonymous just with assisted dying in general. And then within assisted dying, we really have physician assisted dying, or PAD, which means physician prescribed, but administered by patients themselves. And that usually takes the form of oral tablets that are taken PO by a patient. And that difference from euthanasia, which is prescribed medication by a physician or NP, who also administer it as well. And so that means that it can be IV or subcutaneous medications that are actually administered by the clinician. And medical assistance in dying, or MAID, is really just an umbrella term for either euthanasia or PAD, physician-assisted dying. And to give you a sense of where these are legal, PAD is what's legal here in the United States, in the states that it has been legalized, and medical assistance in dying, or MAID, is what's legal in Canada and some other countries. A chronology of the legalization in the United States starts in 1994 with Oregon, which was the first state to legalize PAD. And you can see there's been growing legalization over time, most recently in the areas surrounding New York and the Northeast coast, with Vermont and New Jersey in 2019, and then Maine, and most recently in 2021 with New Mexico. On a global scale, this has been taking place for a lot longer, with Switzerland being the first country to legalize assisted dying in 1942. And then only in 2002, much later, this started to spread throughout more of Europe, with Belgium, the Netherlands, Luxembourg, and then it spread to other countries like Colombia in 2015, Canada in 2016, Australia, and then Spain, New Zealand. There's one approved case in Peru, even though it's not otherwise legal. And then more recently in 2023 with Portugal and Ecuador in 2024. So you can see that there's been growing legalization internationally, with extension into South America, including heavily Catholic areas. So we're no longer restricted to just Western Europe or Commonwealth countries in North America. And I think to keep an eye on for the future may be Chile, which passed a bill in its chamber in April 2021 for assisted dying, and it's been pending a Senate vote since that time. In terms of eligibility in the United States, there are some differences by state, but there are some general criteria that apply throughout the country. And so this is a treatment that's available for adults age 18 years and older. And the main criteria are really about a prognosis 6 months or less with a terminal illness. So that's all determined by a physician, who also has to determine that the patient is capable to make that decision. And there can be referrals made for psychological examination if physicians differ on capacity for the patient. The patient also has to be informed of alternatives to assisted dying. But you can see this process is heavily weighted on physician assessment, particularly with regard to prognosis. The approval process requires submitting 2 oral requests by a primary physician and a secondary consulting physician, and a written request typically by the patient. There's then generally a waiting period of about 15 days. And if a patient is approved, they can then collect the prescription for self-administration thereafter. Again, there are some differences by state, and I'll highlight a few, as some of you may be practicing in these states, or some of these are very nearby to us. So some states do require you to notify next of kin, and that includes New Jersey. Some require a mental health referral, like Colorado or Maine, and some require just one written request. And just of note, Montana actually has no legal protocols at present, but that may change. And the waiting period is a little different state by state. Some places like Oregon allow the waiting period to be bypassed if your prognosis is shorter than that waiting period. New Mexico has no waiting period at all. And California actually recently passed a bill a couple of years ago to shorten their waiting period just to 48 hours. By contrast, New Jersey, and Vermont, and Oregon all have an additional delay of 48 hours to actually fill the prescription after you've been approved. I'll go over a little bit the models of assisted dying around the world so that you can get a flavor of how these practices and eligibility criteria have been put in place and what the differences are and implications for patient care. In the Netherlands, they legalized MAID, so that's euthanasia or physician-assisted dying, since 2002. And their criteria are all based on a physician determination of unbearable suffering with no prospect of improvement. And it's open to anyone who's 12 or older, who is just capable at the time of the request. So that includes mature minors. If their request is voluntary and persistent, and that has to be confirmed and approved by another consulting physician. Things to note about the Netherlands is that they do allow advanced directives, meaning somebody could indicate in an advanced directive that at some point in the future, if they had a certain condition or a set of circumstances, they may want to receive euthanasia, and that could be equivalent to a request. So, for example, if I ever developed advanced dementia, I would want to have euthanasia, even if you're not able to communicate at the time that you would be receiving it. Now, initially, it was really for early stage dementia that this was mostly done for, but they did have their first case of advanced dementia approved in 2011 after a review with the Regional Ethics Review Board. They do have no prognosis requirements in this model, and they also don't have specific illness requirements. So mental illness is permissible as a primary diagnosis. The Swiss were the first to legalize assisted dying, and they really referred to it as assisted suicide. That was really the language that was used at the time that these discussions took place in the early 20th century in Switzerland, and it was really more about rational suicide and the ethics and legality of assisting someone to commit a quote-unquote rational suicide. Should note, euthanasia does remain illegal in Switzerland, but the sole criterion to be eligible is that the motive to assist someone in their dying, it has to be altruistic, not selfish. That's their legal definition. But as a result, there was actually no focus on anything health-related in this discussion or in the criteria. People talked more about values of honor and love driving these motives. And as a result, there's no illness or prognostic requirements involved. Interestingly, there's also no role for physicians specified. This is actually typically done by non-medical organizations. In fact, the Swiss Academy of Medical Sciences stated that assisted suicide is not part of a physician's activity. Now, there are some physicians who participate in these non-medical organizations, but by and large, this is not part of traditional medicine. As a result, it's also available to anybody, all healthy people, though most people who pursue this now in Switzerland are people who have an illness of some kind. The road to legalization in Canada was a bit different. This is a picture of Dr. Don Lowe, who is a Canadian medical microbiologist who was responsible for the discovery of SARS-CoV-1, pre-COVID-19, which really hit Canada very hard, and he rose to prominence in that context. But he developed a brain tumor, and you can see him here in this picture having to hold his eye open with a piece of tape. And he had a video recorded just 8 days before he died that was released posthumously, where he called for access to assisted dying. And in that video, he said, quote, "I'm just frustrated not to be able to have control of my own life when enough is enough." Now, what's interesting about Don Lowe is that he didn't have any pain. He didn't have things that you could think about that palliative care might be able to eliminate. He suffered more from what we call loss of dignity or loss of control of his functions. And at the time that he released the time that this video was released posthumously, the debate was very polarized. It was 2013, and it was kind of unthinkable that assisted dying would be legalized so soon, just a few years later. And it was quite controversial. But what's also interesting about his case is that he had what we might consider to be a quote unquote good death. He died at home without pain, comfortably in the arms of his wife due to his brain tumor, and had received palliative care at home. And that was just 8 days after this film was taken. But this video sparked huge public debate, and you can see that there was a lot of division between what the public view was for assisted dying versus medical opinion. And this was taken in late 2014. On the left, you can see in blue, there was broad public support for allowing physician-assisted suicide, as it was called at the time, about 80% approval. And that differed significantly from physicians' perspectives, where 42% thought it should remain illegal and 13% were undecided. This doesn't specify palliative care, non-palliative care, but there was still no, to this day, national palliative care organization that I'm aware of that explicitly supports or endorses assisted dying. So very disparate views between public and medicine. But what ended up happening is a Supreme Court case in 2015 made a ruling based on a case of ALS that stated that prohibiting physician-assisted dying or euthanasia infringed on constitutional rights to life, liberty, and security. And this led to the passage of legislation, Bill C-14 in Parliament in 2016 that formally legalized MAID. And the criteria were that you had to be a consenting adult, 18 or older, and you had to have a grievous and irremediable medical condition. And that meant that you had to have a serious illness that was incurable and irreversible, where death was reasonably foreseeable. So a bit vague on your prognostic requirements, but generally death would be reasonably foreseeable. And then a patient had to determine that their physical or psychological suffering was enduring and intolerable and unable to be relieved under conditions that were acceptable to them. So this requires both a physician determination about their illness and a patient determination about the nature of their suffering to be eligible. And that was all in 2016. And I started my residency in internal medicine in Toronto in July 2017. And then in August, I had my first case where we had a patient go through a MAID process. And I'll talk about this case a little bit. You can see this is a time when I was still caring 4-pagers in my first year of residency. And this was a 68-year-old man who was admitted to medicine under my team with recurrent GI bleeding due to angiodysplasia. And he had repeated blood transfusions for bleeding that led to iatrogenic hemochromatosis, liver cirrhosis, hepatorenal syndrome, renal failure, and he was on dialysis 4 days a week. He was otherwise fully independent. He was a Chinese Canadian who'd immigrated to the country at age 11. He worked in telecoms, was single, and supported by parents and friends. In hospital, we've been unable to localize his bleeding despite an extensive workup for his angiodysplasia. He continued to have occult and frank GI bleeding and was transfusion dependent every 1 to 2 days. Other than that, with that kind of treatment, he was clinically stable and actually ambulatory on his phone, on his laptop, walking around the unit. But he was basically hospital bound because of the transfusions, his bleeding, and the dialysis. And then on his day 18 of his admission, he requested MAID. So this was very new for all of us and felt contrary to our usual role as a doctor. But we spent some time exploring the sources of his suffering. And he said the following: "This isn't a life I can live. I don't want to live attached to the hospital, and I don't want to die from bleeding out or becoming swollen and confused from my kidneys." We spent a lot of time offering psychosocial support, screening for depression, which he clearly didn't have. And we explored alternatives in depth. And we looked at things like discharging him home with very close 1 to 2 day follow-ups for treatment or transfusions. We looked at palliative and comfort-only care, but he didn't want any of those options, and he continued to request MAID on day 22 of his admission. So we initiated a MAID process, which involved an assessment by a first physician to confirm his eligibility, which was the medicine attending. The patient then completed a formal written request, and he began a mandatory 10-day reflection period. In some cases, that could have been shortened if his prognosis was very short, but in this case, he had his full 10 days. And then we had to get an assessment by a second independent physician to confirm his eligibility. So we consulted what had been established as the MAID consult service by a physician or a nurse practitioner in some cases. There are now even provincial MAID consult services available for this. And once he was approved, we then developed a plan to deliver MAID, which required a lot of coordination with the patient, the family, having meetings, consent, arranging with the other MAID service providers and all the team members who would be involved. And something to note that at the time that we were caring for this patient, legal status required him to be able to give verbal consent, not only when he made the request, but also immediately prior to the medications being administered. Now, that might be a unique experience to Canada or other places where euthanasia has been legalized. But many of you may encounter requests for assisted dying or for wishes to die. And it will be important for you to have an approach to navigating those requests and how to care for patients who seek that out. And I think the general first principles of our specialty still apply. The first thing would be really to explore that request or wish to die. And I would view this as an opportunity to initiate serious illness conversation, exploring their values and their goals like we would for any other patient, and trying to identify potential motivating factors that make them want to seek out assisted dying. And some relevant factors that would be important to consider would include things like their social circumstances, what their living arrangements are, their finances, their support structure, their relationships, their psychosocial milieu, whether they have depression, feelings of meaning in life or self-worth, and their physical symptoms, whether current or anticipated, and their physical function or dependence on others. For many of these people, it may be complex to distinguish depression, or what we might call pathological suicidality, from a rational wish to die, and what's appropriate sad affect in the context of serious illness. And we can use our depression screening like we would if other patients. Many of you will remember the mnemonic SIGI CAPS for depression: sleep, interest, guilt, energy, concentration, appetite, psychomotor symptoms, and suicide. Many of these overlap with illness-related symptoms, and so focusing on the non-somatic ones can be helpful. So this may include affect, so like whether they have a fixed depressed affect, or can they exhibit a range of affect during assessments or in everyday life? Are they able to show interest or enjoyment, engage positively in activities? For older adults, that might be, can they show enjoyment in their grandchildren? Or do they have feelings of guilt or worthlessness? And it's not that these feelings may happen some of the time, which may be normal and appropriate, but that these things are really pervasive. And if you're in doubt, you can always consider psychiatric consultation. Now, in considering MAID and assisted dying, it's always important to consider alternative treatment options as well. And that might be, quite obviously, mitigating any potential motivating factors when possible. So that might mean palliation of symptoms, psychological support, whether that's spiritual support or counseling. Maybe they need social support through a home health aide, whether they benefit from hospice enrollment or transportation services. And then I think it's also important to think about alternatives to MAID in terms of end-of-life care treatments. And often what doesn't get talked about in discussions around assisted dying is palliative sedation, which is distinct and has a separate role in my view, though I think is important to discuss, especially when you're considering alternatives for patients. So I'll spend a moment just talking about that as well. Palliative sedation is sedation for intractable distress in the dying, typically to a point of unconsciousness. And it's based on the 13th century principle developed by Thomas Aquinas about the doctrine of double effect, where your intent is to relieve suffering, not hasten death, even though there's a risk that you may hasten death. Now, this is typically used in the final days of life. Many of you may have seen this used in the palliative care unit most often. And in that setting, for that population, there's no clear evidence that it does hasten death. We don't have any randomized trials to compare, but you could imagine if it was used earlier in someone's course of illness, it may certainly hasten death. All that to say, there's actually no regulation or oversight for palliative sedation as compared to assisted dying, but there's general consensus among bioethicists and medical groups that this should really be for severe and refractory physical symptoms, in addition to having a very short prognosis, usually weeks or shorter. Some people have used this for existential suffering, but there's a lot more controversy regarding its ethics in that context. So you can see how this may be a different population from the profile who seek assisted dying. And we'll speak a little bit about who those people are who seek assisted dying. In Canada, the MAID recipients in 2022 were mainly older adults around 77 years old, but the vast majority were above 56. Pretty evenly split men and women, slightly more men. The main diagnosis was cancer, 63% of cases, but the proportion of non-cancer illness has actually been growing in recent years, with cardiovascular diseases, 19%, respiratory diseases, 13%, and neurological conditions, 11%. Among the neurological conditions, it's about a fifth Parkinson's disease, a fifth ALS, 9% dementia, but most of the rest aren't actually specified. The vast majority receive palliative care, about 78%, and people who receive MAID are actually more likely to be high income or married. And that's pretty similar with what you see with the profile of assisted dying recipients in the US. Pretty even gender distribution. The vast majority are non-Hispanic white, so that's 96% overall in the US. Median age is similar, around 74, and around 3/4 have at least some college education, with cancer being the most common diagnosis, around 70%. And I show you here the stats for New Jersey in 2022, which has legalized it since 2019, just because it's the state most near us, and some of our patients may reside there and may seek it out. And there were 90 reported cases of physician-assisted dying in 2022. Pretty even gender distribution, and again, vast majority non-Hispanic white, some Asian participants, or I should say recipients, but I just want to point out that the first year that they had any Black or Hispanic recipients was in 2022. So there may be demographic changes over time, even if they're very subtle right now. We have some data about the nature of suffering for MAID applicants from Canada, because it's part of the eligibility criteria to receive MAID. And so there's actually a lot of data collected on this in that location. There's a number of reasons people seek it out, and I'll highlight some of the most common ones. The vast majority of people talked about loss of ability to engage in meaningful activities or to perform activities of daily living. Over 80% of people cited that as a reason. The next most common, with over half of participants reporting inadequate control of pain or other non-pain symptoms, or concern about developing those symptoms. Interestingly, over half of the people also cited loss of dignity as a major source of suffering. And then you have almost a third, or over a third in some cases, reporting perceived burden on family, friends, or caregivers, or loss of control of bodily functions. And they actually have done some qualitative studies to get at what people are reporting when they seek out MAID. And this one study done in 2018 found one patient saying, in fact, when you live with something like this and life is such a struggle every day, you almost welcome the end. You go, I don't want to struggle anymore. And it's not something that, Zoloft or Prozac is going to be able to help. Another patient said, the deterioration is ongoing, inability to chew and swallow. I can't open a door with keys. A knife and scissors and zips are a real challenge. I can't do stairs or steps anymore and can no longer step into the bath. Lack of control of the bowels is a special misery. A third patient said, I don't want to have to take matters into my own hands. I want options. I want choice. I deserve that. We all deserve that. Now, they've also done studies of nursing experiences with MAID, and there was a lot of apprehension in the nursing staff before MAID was actually delivered and implemented, and even a lot of distress beforehand among those without any clinical contact, like pharmacists. But they did a study in 2020 looking at nursing experiences among nurses who did choose to deliver MAID, to be involved in the delivery of MAID. So anyone who had a conscientious objection or didn't feel comfortable was not part of the study. So there may be some selection bias here. But it turns out for those who chose to be involved, it seemed like it was a very rewarding experience. One nurse said, it was very rewarding. I was happy for him because this is a long time coming. I have in my job been watching people suffer for days and days and days when they have no control of when it's their time, and he was very happy and grateful. Another nurse said, it's just a nicer, smoother process. People can say goodbye. They have the ability to talk to that person right up until a few minutes before they die. It's really kind of calming somehow because they expect it to happen and they know what's coming next. So, for people who are comfortable having MAID and providers who are comfortable doing it, this can be a positive experience. Probably more of the controversy is about who should be getting it and how it's evolved over time. And what you'll notice from the responses from recipients and from nurses is that autonomy is one of the things that's highlighted most by those who receive it. And the advocates for MAID also highlight respect for autonomy of the individual. It's really a main feature. And the people who say that often take this to be a universal value, but we know that it isn't. In other places like Asia or Africa, this is less common. And there's more emphasis about family over personal autonomy in these places. I have here a picture of the cover of a book by Dr. Christian Nitsamera, who's a palliative care doctor in Rwanda, who just came out with this book recently that I recommend called The Safari Concept, an African Framework for End-of-Life Care. And in the book, he has a quote, and he says, this is a saying in Rwanda, when you are well, you belong to yourself, but when you are sick, you belong to your family. So there's a lot more emphasis on connection to family when you're ill in some other places like Rwanda. And I think it's similar in some ways to concepts of filial piety or xiao in East Asian cultures, where responsibility to family is much more common. This isn't to say that anyone from any one of these backgrounds will automatically have this value structure, but this emphasis on autonomy of the individual over other values is just not a universal phenomenon. So back to our case, Mr. F, who is actually a Chinese Canadian as well. Just to remind you where we left off, we had consulted the MAID service. The patient was approved by 2 assessors and deemed eligible, and he had completed his 10-day reflection period. We then arranged a family meeting with patient, his parents, a Mandarin interpreter, the nephrologist with whom he had a very close relationship, and the medicine team, of which I was a part. And in the meeting, it was particularly hard for his mother to accept his decision. Obviously, she didn't want her son to die, and I think it was hard for her to accept that he might make a choice like this. We spent a long time exploring his goals, his values, things that were unacceptable to him, the nature of his suffering. And in the end, his mother understood where he was coming from and accepted that decision. And so we had made a plan from that time to coordinate MAID to be delivered that following week. It was planned for a Wednesday. And I remember saying to the patient afterwards, so you're just going to die on Wednesday? And he said, yeah, I'm just going to die on Wednesday. And he really appreciated that certainty. And there were a lot of logistics that then kind of got swept into motion, coordination with the MAID team, the clinicians who would be involved, the nursing staff, the pharmacists. We ordered IV medications that were going to be used for MAID. And these specifically were midazolam, lidocaine, propofol, and rocuronium. That differs from what you'd get in PAD here in the US, which is usually an oral tablet, usually phenobarbital or some barbiturate. And the MAID team then administered that procedure on a Wednesday, day 34, at his bedside. And at the end, the family and the medical team who were involved viewed this as a quote unquote good death because it was aligned with what the patient had wanted and he wasn't suffering and was able to have his family at his bedside. Now, when discussions about assisted dying have taken place, whether before legalization or after legalization, there's rightfully much discussion around the potential for a slippery slope and a lot of concern around abuse of this treatment or procedure. And a big concern initially and ongoing has been, will MAID be driven by socioeconomic deprivation or poor service availability, such as lack of palliative care, and would therefore be disproportionately and perhaps inappropriately administered to minoritized or socially vulnerable individuals. And what we've found from data that exists in every jurisdiction where it's been legalized is that palliative care is received by the majority of MAID recipients. So it's at least not a service availability related to palliative care that we can identify. And the vast majority of recipients are white, higher socioeconomic status, educated individuals, typically with low support needs, who are really the majority of recipients in every place where it's legal. Now, we know that that doesn't capture all forms of social vulnerability. Loneliness can still be present among the affluent. And it's possible that as MAID becomes more normalized, where it's already legal, some of the demographics may begin to change. We've noticed very subtle changes in 2022, so it's something certainly to be mindful of, though we haven't been able to identify this as a major problem currently. Doesn't mean that it doesn't happen for some individuals in some places and that it may not happen in future. But it hasn't been the major thing that we've noticed so far in MAID legalization in places where it's legal. The second area of concern about slippery slopes has been whether it would undermine palliative care. But despite concerns about this, there's also been no evidence to support that either. There's actually been greater public awareness and demand for palliative care following its legalization. And like we said, the majority of MAID recipients do receive palliative care. In fact, they may be more likely to receive palliative care. There was a Belgian study done in 2007 among 6,800 people who died and found that people who requested euthanasia were more than twice as likely to receive palliative care compared to others who died of non-sudden causes. So rather than abuse or neglect, which may still be an important thing to be thinking about, the slippery slope that has played out more often or more obviously in practice is one about the widening indications and broader scope for MAID. And that legalization has really been the thin edge of the wedge that's driven broader application of MAID to other populations. And that may include mature minors. It may include mental illness as a primary indication. There's actually a vote on that that's still pending in Canada. Death not being reasonably foreseeable, so not having any prognostic criteria, and that's also now been legalized since 2021 in Canada. Having advanced consent, so making a request while you're capable, but then not necessarily needing to be capable at the time that you receive MAID or other forms of assisted dying. That's also since been legalized in Canada in 2021. Advanced directives have been legal in the Netherlands, where someone may indicate in advance that if certain conditions are met, they may want to receive euthanasia, even if they're not able to communicate at that time. This is a particular concern for older adults and the elderly, especially as I've seen some people use actuarial survival to make a bit of a fudge around prognosis and whether someone meets criteria for foreseeable death. I think of a 91-year-old woman who lived in a nursing home with COPD and multimorbidity with cataracts, visual impairment, hearing impairment, and she had really just lost pleasure in her activities and had this quote unquote tired of life syndrome. And somebody approved her for MAID by saying that her predicted actuarial survival was 3 years. So that's a particular concern for this population, and especially for people who have dementia or who are frail. And speaking of dementia concerns, there was a narrative study done in the Netherlands of all the cases of euthanasia in dementia. And remember that this is a place that allows advance directives. So you can specify in advance that you would want to receive euthanasia, even if you're not able to speak at that time. And it used to be only for very early stage dementia and was really done uncommonly in the early 2000s. But I mentioned earlier, they had their first case of advanced dementia approved in 2011. So this narrative study looked at the 111 cases of euthanasia for dementia, which represented about 1.3% of all dementia mortality. And among those cases, they found that 38% reported that living in a nursing home was the source of unacceptable or unbearable suffering for which they might seek euthanasia. And they found that 10% of cases were not fully competent. So within those, they found that some of those cases had euthanasia administered despite mixed signals suggesting possible refusal. And specifically, this study found that in one case, they said, although the patient again indicated that he was doing well and that he did not want to die, the doctor decided to continue the euthanasia process. So there was also this other kind of separate cases in 3 instances where relatives actually refused palliative measures to make sure that the patient was, quote unquote, suffering enough to meet the euthanasia requirement of unbearable or unacceptable suffering. So these are very concerning cases when we think about people with dementia and older adults. And there are other domains beyond just dementia and beyond just advanced directives where this is a particular concern. This is a case that was widely publicized in November 2020 in Canada about MAID in the social environment. And it was of a 90-year-old woman who chose medically assisted dying rather than face another retirement home lockdown due to COVID-19. And her family described her as exceptionally social and spry, and that she declined so sharply during lockdown that she didn't want to go through more isolation this winter. And she did receive MAID. Now, certainly that social environment beyond COVID applies to many other conditions. And so that concern about slippery slope is very real, and it's already happening in Canada as well. In 2019, there was a Superior Court of Quebec case that found that the criterion for having a reasonably foreseeable natural death, this prognostic criterion, was unconstitutional. And that led to legislation passed, Bill C7, in March 2021, that eliminated that prognostic criterion. So they now have 2 pathways for assisted dying, one where your death is reasonably foreseeable, and one that your death doesn't have to be reasonably foreseeable. That second pathway has additional safeguards. They have a mandatory 90-day reflection period, and you have to be assessed by a clinician with expertise in that patient's condition. For those who do have an imminent death, the they do have the option to have advanced consent. And that's waiving that final consent immediately before you receive the assisted dying medication. And that was based on a patient, Audrey Parker, who actually chose to receive MAID earlier than she would have otherwise chosen so that she wouldn't risk losing capacity and being ineligible to receive MAID thereafter. So that's now available. And they also had made eligibility for mental health diagnoses to be possible. That was initially meant to be implemented in March 2024, just this past March, but there was felt that there weren't sufficient safeguards yet in place. And so that was deferred, and it's still pending a final vote. And so you can see that what was once very controversial at the beginning has now become widely accepted and very normative in Canada. And it's actually the place that has the highest rates of assisted dying in the world. And that's why I focus on it a little bit here. You can see that MAID now represents 4.1% of all deaths as of 2022 in Canada, and that was compared to 2.5% in 2020. By comparison, in the Netherlands, it accounts for 1.3% of all deaths. And in Oregon, where it's been legal since 1994, it's 0.8% of all deaths. So it's really exploded exponentially. And you can see in the graph on the right, the red parts of the bars indicate this additional pathway that was legalized recently, where you don't have to have a shorter prognosis. You don't have to have death reasonably foreseeable. Most MAID requests are approved. About 88% are approved as of 2022. About 13% of people who request it die, usually of their condition or some other cause prior to receiving it. About 6% are deemed ineligible, and 2% withdraw, with most of them due to changing their mind, and about 40% citing palliative measures being sufficient. But overall, you can see about 20 to 30% growth each year since its legalization. And that's been true in other places, and including the United States. And I show here California because it actually has the same population, 39 million people, as the entire country of Canada. And you can see the difference in the numbers, where we had 13,241 MAID deaths in Canada in 2022. There were, by contrast, 853 deaths by physician-assisted dying in 2022 here. And that there was more prescriptions written. There was 1,200 prescriptions, but 853 deaths. And similar outcomes about what happens with the prescriptions. Most of them die by that ingestion. 14% die by other causes or their illness. And about 20%, they don't know the ingestion status, or they may not have taken the medication, or they may not have died yet. But you can see the same growth year on year, with actually in the last year from 2021 to 2022, there's about a 47% increase in assisted dying deaths. And that's true in every state where it's been legalized. Here's an aggregate of physician-assisted prescriptions and deaths since 1999 until 2020. The solid lines show the prescriptions, and the dashed lines show the deaths. And they've been steadily increasing in every jurisdiction where it's legal here too. And thinking about the lessons we may learn from the US, Canada, and abroad, what we've seen is that the legalization of MAID arose really from the public, despite medical opposition from medical professional bodies and individual physicians. And this really was about public campaigns and advocacy that eventually led to legislative changes that imposed a new reality on the medical community. But eventually, once these things were legalized, it led to rapid change in medical opinion, culture, and practice, where these things are really normative now in places where they're legal. And what we've found so far is that initial fears about abuse of certain populations haven't currently been identified, although we should always be on the lookout. It doesn't mean they don't exist in some cases. What we have been seeing play out more obviously is less expected ones about concern for older adults, those with dementia and frailty, and just broadening indications and growth overall of assisted dying. Now, the guidelines on assisted dying and the policies around it have really been driven mainly by advocates, and it's been without the engagement of most mainstream and palliative geriatric communities, which is unfortunate because I think their voice is important. We all, as specialists in these communities, have very important skill sets to bring. And regardless of your personal opinion about assisted dying legalization, it's likely coming to a state near you or already exists, like in nearby New Jersey. So, it doesn't really matter whether you think that it should be legalized or not, or whether you think that it should be fully part of palliative care as a service that we provide, or completely separate where we don't even engage with it. What happens before and after is really part of the purview of end-of-life care. I liken it to, being a cardiologist. If you have a patient undergoing a coronary catheterization, you may not be doing that procedure yourself, but you're very much should be involved in what happens before and after. And I think, there's very important skill sets and knowledge and expertise that we may be able to bring to these important clinical questions and policies to help coordinate with our specialties. And so I'll leave you with that thought as you ponder what our role may be for future questions about assisted dying. And I'll leave you with this meme to think about as well. And I'm happy to talk more with anybody who's interested. If you have questions, comments, feedback, anything, I'm happy to chat anytime. My email is listed there, rebecca.roden@mssm.edu. Thank you very much.